A very good day to all. Today's class is liver trauma. Coming to the background of this liver, it's a single large organ and a fixed position it has got. And in a trauma, the second most organ after spleen is injured is our liver. Most common cause of death after abdomen trauma is also because of liver trauma. And most mode of injury is blunt injury only. And the best thing about the thing is you can manage them conservatively in about 80% of adults and to 95 to 97% in children. The pathophysiology behind it is it's got a very friable parenchyma, a thin capsule, fixed in position with relation to spine, and most of the time the right lobe gets hit more because it's very closer to the ribs. And 85% of the injuries involve your 6, 7, and 8 segments, which get compressed between the ribs and the spine and the abdominal wall, and shear force of attachment to the diaphragm. So all those things can cause the trauma. The liver is easily also injured in children because the ribs are very compliant. So the force is transmitted across the ribs to the liver straight. And because the ribs will not break, the bones. So as I was saying, the liver injury in children is easily more common because of the ribs being compliant and the force directly transmitted toward the liver, and the ribs won't break, just compile. Okay. And liver is not as developed in compared to adults. In adults also, as you saw, it is a very friable thing. In kids, is furthermore weaker with connective tissue framework, a weak connective tissue. Other modalities of injury which can happen is through iatrogenic injuries, like when you take biopsies or biliary drainage or when you do a TIPS procedure. The injuries can be listed as subcapsular hematoma, laceration, contusion, and hepatic vascular disruption, and bile duct injuries. So, if it's a mild injury, that means it's involving just only the 25% of the one lobe and might heal in within 3 months. If there's a moderate injury, when there is 25 to 50% of the lobe heal in 6 months. And if it is severe injury, it will take out almost 1.5 years to heal. And gallbladder injuries also can be seen, and most commonly contusion and avulsion. 86%, if you see, they stop bleeding when you go to explore and require transfusion. That's all, decrease required. And that's why most of the time we choose a conservative line of management. Now coming to the anatomy, Cantal described a plane between the gallbladder fossa and the inferior vena cava and divides the liver into equal halves. Okay. Now, Cugnot developed 4 segments, sectors, and 8 segments, which again divided into vertical and oblique planes, defined by 3 main hepatic veins, transverse plane through right to left portal branches. And of course, the hepatic vein lie between the segments. The left hepatic divides the left lobe into median and lateral segments. The middle hepatic vein divides the liver into left and right lobes. The right divides into anterior and posterior segments. The horizontal line, though left and right main portal veins, is used to divide lobes into inferior and they say all the whole leading into 8 liver segments, numbered clockwise from the front view. So if you see, the one is a caudate lobe, followed by in the left lobe, if you see there are 2 and 3, followed by 4, 5, 6, 7, and 8. So this is how the segments are divided. So, and similarly, you have a biliary tree also according to each segment. And so each segment will have three components: a hepatic artery, a vein, and a duct. So this is what is the component. So if you see again as a similar falciparum ligament dividing into two lobes, basically left and right. In the left we have segment 2 and 3. One is the caudate lobe. Segment 4 again is divided into A and B. Segment 5, segment 6, 7, 8. So this is how the segments are. So this is the further venous thing and the all three together. So this is a hepatocyte. If you see carefully, you have all the three sections here in the middle. This is the duct, the artery, and the vein. So all these things together forms the parenchyma of the liver. Now, clinically, if you see, symptoms of injury are related to blood loss and peritoneal irritation. So you can have a right upper quadrant tenderness, guarding. Uh, they can have unrecognized delay. If there is a delay, you might have lead into abscess. And bilioma is also very common. And signs of blood loss may dominate the picture, like in terms of hypovolemia, tachycardia. In investigation, you'll have elevated liver tests. Of course, biliary pancreatitis also, peritonitis can lead to have a nausea and vomiting. A diagnostic petrolab is highly sensitive and 1 to 2% complications. So we can prefer to have a diagnostic petrol lavage. Plain X-ray are non-specific with respect to liver, and CT can be diagnostic of choice. Hydroxy immunohechida scan is for leaks and angio is for hemorrhage. So you have all the modalities we can cover for diagnosis. So this is the typical HIDA scan where you can see the bile ducts, if at all. This is the CBD bile duct, and this is the normal liver. Fast sensitivity is highest and 98 for grade 3 injuries or greater. A little lesser injury, it might not show us, but a negative finding do not exclude a hepatic injury. So that's what we need to know. So a fast scan is sensitive, but you should have a higher grade of injury. So emergency endo, we just want to see whether any injury is there. Then we just have to see for free fluid, uh, parenchymal injury, or both demonstrate overall sensitivity for detection of blunt injury trauma. Angio may fail to detect active bleed also. That also should be kept in mind. CT scan, of course, accurate localizing site of injury according to the injury, and of course used to monitor healing also. And the criteria is there based on the American Association of Trauma and grade 1 to 6. Hematoma, laceration, vascular injury, acute bleeding, gallbladder injury, and bilioma. That's how it is going to be. Now coming to that AAST classification, which divided into the first one is a supracapsular hematoma, which is just less than 1 centimeter, or you have a superficial laceration less than 1 centimeter deep. The second class of trauma is your parenchymal injury 1 to 3 centimeter deep, a subcapsular hematoma, and 1 to 3 centimeters thick. Third is parenchymal laceration more than 3 centimeter deep and a subcapsular more than 6. So we have same is simpler 1, 1 to 3, 3. So that's the initial 3. The other grades, if you go, is exponentially more than 10. So it's a 3 to 10 centimeter is probably grade 3. You have a grade 4, that means more than 10 centimeter in diameter. You might have a lobar disruption, or you can have devascularization. So these are the things you get to see as a grade 4 injury. And of course, 5 is a global destruction or devascularization of the liver. And 5th is the whole hepatic thing is avulsed. Our liver is avulsed. Of course, coming to angiography as a role of liver trauma, demonstrates active bleeding. Transcatheter embolism can be the only treatment required at times, and findings include contusion, laceration, hematoma, and pseudoneurous fistulas. All those things can be found out very easily on the angio. Embolism can reduce the transfusion requirement also, and stenting of fistula also can be done in angio. So there's a new opening for a conservative management. So if you see, that's the how angio will look of a liver. And this you can do a trans hepatic procedures through this. This is our grade 1 injury. We said it is just about 1 centimeter less than, the subcapsular hematoma. Very difficult to find on a CT also. If you see is a thin rim here, the diagrammatic representation will give a better picture. But if you see on the original CT, is you need to have good eye and experience to note this contusion. So that's the grade 1. The grade 2, you can see nicely a little furthermore hematoma, subcapsular hematoma. So that qualifies on the CT grade 2. Grade 3, you can nicely see a very nice concave, convex appearance here. And there's another contusion here also. This is the normal, this is the gallbladder, parenchymal contusion. The GB will be somewhere here. This is the stomach, this is the spleen. So that's thing on the CT. And you see a little worser grade where there's lots of devascular and the lobular disruption is there, and a big hematoma around the capsule. So this will form a grade 4 and mostly uh, more than 10 centimeters. So that will form the grade 4 injury. Okay, fine. The grade 5 injury is much worser. As you see, there's lots of devascularization going on and hardly any normal thing you can see. This is the other form where the vascular pedicle and other things have gone, and there's a small hemangioma around the IVC. So all those things constitute a very severe injury. So for the people, kindly go through the presentation, and I need you to send a assignment wherein you will be showing me the liver segments. I need to be drawn by you, labeled, and you will give me the grades of liver injuries. And you can mail it to our department mail, slims@gmail.com. That's what I want in a A4 sheet, one labeling like that with the classification of grades of injury. Thank you. Any queries can be sent through the mail or you can contact me in person in the department. Thank you.